Hi friends, in this video we shall be discussing a very important topic which is Men's syndrome. So what is MEN stand for? It is multiple endocrine neoplasia. So what is MEN syndrome? They are group of heterogeneous disorders which are characterized by benign by benign and malignant tumors involving two or more endocrine glands. There are four types of MEN syndrome, of which MEN type 1 and MEN type 2 are the most commonly MEN syndrome seen. Now, what is the mode of inheritance of MEN syndrome? Please, there is no confusion regarding it. It is autosomal dominant. Now, let's discuss a few important points regarding MEN 1 and MEN type 2 syndrome. So, first regarding MEN 1. MEN 1 syndrome is also known as Wermer syndrome. Please pay a specific emphasis on the letter M, as there is another syndrome which is called a Werner syndrome, spelled with WERNER syndrome, which is a syndrome involving rapid aging. However, MEN 1 is a Werner syndrome. Right. So what happens in MEN 1 syndrome? Over here, gene involved is MEN 1 gene. This MEN 1 gene is a tumor suppressor gene, so which encodes for menin. This menin protein is in turn responsible for regulating the transcription, the cell division, and the proliferation. So, what happens is that there is a two-hit methodology which causes first a germline mutation followed by a somatic mutation which is responsible for MEN type 1 syndrome. On the other hand, in MEN 2, we have a proto-oncogene involved. Right. So please remember, in MEN 1 there is a tumor suppressor gene involved, whereas in case of MEN 2 it is a proto-oncogene involved. Which proto-oncogene are we talking about? It is the RET. Now, what this RET does is that it encodes for tyrosine kinase membrane receptor. Now, this activates the pathway involved in the proliferation, survival, migration, and angiogenesis. So, in case of MEN 2 syndrome, there is a gain of function. Please remember that no, there is no loss of function mutation, but rather the gain of function mutation of RET proto-oncogene, which causes the activation of tyrosine kinase receptor, as a result of which cancer initiation through deregulation, proliferation, and increased survival. Right. So I repeat for you all what is MEN 1 and MEN 2. In cases of MEN 1, we have a tumor suppressor gene involved, which is the MEN 1 gene, which encodes for the menin protein that regulates transcription, cell division, and proliferation. So there is a two-hit methodology causing the germline mutation first and the somatic mutation, which in turn is going to lead to MEN 1 syndrome. In case of MEN 2 syndrome, we have a proto-oncogene involved, which is the RET proto-oncogene, which is encoding for the tyrosine kinase membrane receptor that activates the pathway involved the proliferation, survival, migration, and angiogenesis. And there is a gain of function mutation which causes the activation of tyrosine kinase receptor and initiation of the cancer through dysregulation, proliferation, and increased survival. So, where are these genes located? In MEN1, which is caused by the tumor suppressor gene menin1 gene, is located on the chromosome number 11, whereas in case of MEN2, which is caused due to the proto-oncogene red, is located on the chromosome number 10, right? And now there's another important difference that you need to know about MEN1 and MEN2 is regarding the genotype and the phenotype association. In MEN1, we do not have any genotype or phenotype association, whereas in cases of MEN2, we have a strong genotype and a phenotype association, the importance of which we shall be discussing later on in the discussion of the screening of MEN2 syndrome, right? So now let's go to the various tumors that are present in this MEN1 and MEN2. So first we begin our discussion with the MEN type 1. So MEN type 1, has an incidence or prevalence in 1 in 30,000. So what are the tumors that are present in MEN type 1? Please remember it as 3 P's. So what are your 3 P's over here? It is parathyroid, it is pituitary, and it is pancreas. So we have our first P, which is parathyroid, right? So now you know that in parathyroid there could be an adenoma or adenoma of the parathyroid gland, or there could be hyperplasia. So in MEN type 1, in case of parathyroid, hyperplasia is much more common than adenoma, right? So it is hyperplasia much more common than adenoma. So what would be the clinical presentation in such patients? They may be associated with renal lithiasis and presence of any skeletal lesion. At the same time, it might have metabolic abnormalities in terms of increased serum calcium and parathyroid hormone level. The second P that we need to remember is pituitary gland, right? So in case of pituitary, there would be two parts of the pituitary, anterior and posterior. So which is the most commonly involved? It is the anterior pituitary, which is the most commonly involved part in MEN type 1 syndrome. Now what is the most common lesion that is found? So the most common lesion that is found is prolactinoma, and they may be associated with galactorrhea and amenorrhea. Now, so we have done with the 2 P's, which are the parathyroid and the pituitary, and the third P that we need to remember is the pancreas. So what happens in pancreas? There is increased neuroendocrine tumors, and which is the most commonly neuroendocrine tumor found? It is gastrinoma, which is more commonly found than the insulinoma. And the most common non-functional tumor that is found is pepoma, right? So please remember that in MEN1 syndrome, in case of pancreas, there is increased neuroendocrine tumors, and gastrinoma is much more common than insulinoma, and the most common non-functional tumor is the pepoma. And also remember that pancreatic neuroendocrine tumors are most common cause of death, right? So now there are some other tumors which may be also associated with MEN1 syndrome, which include bronchial, thymic, gastric carcinoid, lipomas, facial angiofibromas, benign thyroid neoplasms, and some adrenocortical tumors, right? So let's summarize the clinical manifestations of multiple endocrine neoplasia type 1 with the help of this table that we have. So we have tumor site PHPT, which is the 4-gland disease involving the parathyroid, which has a frequency of around 95. Then we have pancreatic islet cell tumors, which has a frequency of around 30 to 80%. right? And as we said, gastrinoma is common, and in case of non-functional pepoma are more common. Then other neuroendocrine tumors that may be present include vipoma and somatostatinoma. Pituitary tumors, in which, remember, anterior is most commonly involved. We have prolactin, the most common tumor present. Then other tumors that may be present would be from the growth hormone, ACTH, and non-functioning. Then we have adrenocortical tumors, which are mainly non-functioning, lipomas, neuroendocrine tumors of lung, thymus, stomach, and it is also associated with meningiomas and facial angiofibromas. Right. So this were the clinical manifestations of MEN1 syndrome, where I would like you all to remember at least the 3 P's: pancreas, pituitary, and parathyroid. Please do not forget this basic thing in MEN type 1. Now, regarding the diagnosis of MEN1 syndrome, so what is the criteria? It is the involvement of at least 2 of 3 target organs. And in case of familial men, it is involvement of any organ in first degree relative, right? So there are some screening protocols for the MEN1 syndrome. So let's look at them. So first is the genetic testing at birth. So what are you going to do the genetic testing for? We had seen in MEN1 we have the menin1 gene. So we shall be genetic testing at the birth. Now if it is negative, then MEN1 is ruled out, right? Then at the age of 5 years we begin. Please remember those 3 P. So we'll be beginning with one of the P. So we begin over here. Annual pituitary screening. Right. So how do we begin the screening with? We begin with the serum prolactin. Please again go back to the part of the video. The most common tumor involved in the pituitary is prolactinoma. Right. So serum prolactin. Now, if this is elevated, then there would be need to do what? Yes, magnetic resonance imaging, which is the MRI scan. Then at the age of the 8 years, we begin the screening of the second P over here. The second P would be over here, the parathyroid screening. How do we begin it? With serum calcium and PTH levels. Now again, if this is elevated, if this is abnormal, right, abnormal and elevated, then what do we go for? We go for SESA-TMB scan, right? Now the remaining third P, which is the pancreas, we begin the screening at the age of 20, right? So over here we begin the pancreatic neuroendocrine tumor screening, right? So the screening begins at the birth. We do the genetic testing, followed by at the age of 5 years, which would be the pituitary screening. Then at the age of 8 years, which would be the parathyroid screening, and at the age of 20 years, which would be the pancreatic neuroendocrine tumor screening. So now coming down to the treatment part. So what shall we do for parathyroid? We know that in parathyroid, it would be the hyperplasia, which is more common than adenoma. So this would require a 3.5 gland parathyroid ectomy. Now, if all the 4 glands have to be removed, that is, if the patient is requiring total parathyroid ectomy, then in this cases we need to go for an auto implantation of a parathyroid gland, right? So it is an auto implantation, right? Where is it done? It is done in which muscle, right? It is done in brachioradialis. It is done in brachioradialis, and it is done in the non-dominant hand, right? So for parathyroid, since hyperplasia is more common, we go for a 3.5 gland parathyroidectomy. Now, if total parathyroidectomy is being done, then an autoimplantation is to be done in brachioradialis muscle in non-dominant hand. Now, in cases of pancreatic neuroendocrine tumor, we know the most common is the gastrinoma. So, what do you do in gastrinoma? You would be requiring a resection plus lymphadenectomy. Now, in case of insuloma, you might be requiring a enucleation, and in case of a non-functional tumor, again you would be requiring a resection, right? And in cases of pituitary tumor, right, we had seen, again I revise, it's anterior pituitary, and the most common lesion is the prolactinoma. So what would you be doing over here? You would be going initially for the medical management. Medical management usually with spironolactone, right? Now, if this fails, right, normally it gets cured with the medical management. If fails, then we go for surgery, right? So this were the few important points regarding your MEN1 syndrome. Now we shall shift to our discussion on MEN2 syndrome, right? So in MEN2 syndrome, we have two types of MEN2 syndrome, which is type 2A and type 2B, right? So the incidence of type 2A is 1 in 25,000. On the other hand, type 2B is 0.2 in 1 lakh. So what are the tumors that we see in MEN2A and what are the tumors that we see in MEN2B? So let's enumerate the tumors seen in MEN2A and MEN2B. So first, let's enumerate the tumors in case of MEN2A, right? So in MEN2A, we have MTC, which is medullary thyroid carcinoma. Then we have a pheochromocytoma. Then hyperparathyroidism. Hyperparathyroidism. Other tumors include, other conditions over here include Hirschsprung disease, right? Then cutaneous lichen amyloidosis. So in MEN2A, we have medullary thyroid carcinoma, pheochromocytoma, hyperparathyroidism, Hirschsprung disease, and cutaneous lichen amyloidosis, right? So where is the most common location of this cutaneous lichen amyloidosis? It is usually in the interscapular region and the extensors, right? So the most common location is interscapular region and extensors, right? And what are the tumors in your MEN type 2B? So we again have MTC, which is medullary thyroid carcinoma. Let me write it down for you. Medullary thyroid carcinoma. Other conditions include pheochromocytoma. Then we have mucosal neuroma. So what are the most common site of mucosal neuroma? The most common site includes lip and buccal mucosa Then we have some GI neuromatosis, right? Then we have Marfanoid features. Then we have megacolon and constipation. Megacolon and constipation, right? So these are few of the conditions that are associated with MEN2A and 2B. Let's summarize each of them Again, in cases of MEN2A, we have medullary thyroid carcinoma, pheochromocytoma, hyperparathyroidism, Hirschsprung disease, cutaneous light chain amyloidosis, the most common location being the interscapular region and the extensors. In cases of MEN2B, we have medullary thyroid carcinoma, pheochromocytoma, we have mucosal neuromas, the most common site being the lip and the buccal mucosa. We have GI neuromatosis, Marfanoid features, megacolon, and constipation. Right. Then comes another entity, the familial medullary thyroid carcinoma. Right. So this is the subvariety of MEN2 syndrome. What happens in this is that medullary thyroid carcinoma occurs in isolation. Right. So over here we had discussed that MEN2 syndrome is medullary thyroid carcinoma is being associated with so many other conditions. But in case of familial MTC, it is a subvariety of a MEN2 syndrome where MTC occurs in isolation. Then we have another syndrome called as Sippel syndrome. So what is Sippel syndrome? Sippel syndrome is medullary thyroid carcinoma plus pheochromocytoma. Pheochromocytoma. Right. So please remember, you might get an MCQ like Sippel syndrome consists of option A medullary thyroid carcinoma, option B pheochromocytoma, option C both, option D none, or there could be a lot of permutation and combination. So please, this is a direct one-liner of Sippel syndrome. Now coming down to the screening part of the MEN2 syndrome. Right, the screening would include the red proto-oncogene mutation and pentagastrin stimulated calcitonin. Right, the diagnosis like in MTC would include increased calcitonin, increased CEA, and red proto-oncogene mutation. Whereas in case of a pheochromocytoma, you would include plasma-free metanephrines and 24 hours urine-free metanephrines. If there is a hyperparathyroidism, there would be increased in serum calcium, increase in parathyroid levels, and sesatiMB scan could be done to localize the parathyroid lesions. Right. So this is an image taken from your textbook Bailey and Love, where you can see the ganglioneuromatosis over here, which is I'm shading it with the green of your oral mucosa, which is seen where, in which type 2A or type 2B? Yes, it's type 2B. So please again come back to the type 2A and type 2B. Right. So please remember that this mucosal neuromas or neuromatosis or Marfanoid features are characteristics of type 2B syndrome and not type 2A. So this could be your clinching points which might give you clue to diagnose type 2A or type 2B. Please remember that mucosal features are associated with type 2B and not type 2A. Right. So coming back to it, the image. So this is the image which is having the oral mucosa, which is seen in type, yes, it is seen in type 2B. Right. So what would your management include? The management would include for first the medullary thyroid carcinoma. So what would be your management over here? So for medullary thyroid carcinoma, you would have to do a total thyroidectomy with prophylactic CND. What is CND? It is central neck dissection. Right. And if the central node is positive or the gland is more than 1.5 centimeter, you would need to do a bilateral neck dissection. Right, you would need to do a bilateral neck dissection if central node positive or gland more than 1.5 centimeter. So in case of medullary thyroid carcinoma, please remember it would be total thyroidectomy along with neck dissection. You would generally require a bilateral neck dissection if the central nodes are positive and the gland is measuring more than 1.5 centimeter. Now in cases of pheochromocytoma, you would need to do a lap or open adrenalectomy. Right, the parathyroid over here usually do not require any treatment. Now, coming towards the end of our discussion, there was something which we had discussed at the beginning of our video, which was with respect to the genotypic and the phenotypic association. We had seen that this genotypic and phenotypic association is most commonly seen in men type 2. So, what are this genotypic and the phenotypic association that we have seen? So, if you see over here, we have the syndrome on the one side of the table, which is men 2A, familial medullary thyroid carcinoma, and men 2B, the frequently affected red gene codons, right, and the percentage of the tumors that is happening. So, see, in case of men 2A, the frequently affected red gene codons include 609, 634, 804, and 790. In cases of familial medullary thyroid carcinoma, we have 533, 630, 768, and 844. And in case of men type 2B, we have 883 and 918. So on the other hand, we have the various tumor associations, which is 90 to 100% of medullary thyroid carcinoma, 20 to 30 primary hyperparathyroidism, and pheochromocytoma of around 10 to 70 in men 2A. In familial medullary thyroid carcinoma, we have only medullary thyroid carcinoma, which is 90 to 100, and in men 2B, we have 100% of medullary thyroid carcinoma and 10 to 60% of pheochromocytoma. So how is this association going to help? So we have children who carry MEN2 mutation are screened for calcitonin, right, to detect the presence of precursor to medullary thyroid carcinoma cell hyperplasia. Now, what it does is that it allows the thyroidectomy to be taken before the invasive medullary thyroid carcinoma has developed. Now, owing to this strong genotype-phenotypic relationship, specific mutation can guide regarding the timing of prophylactic surgery, right? So this genotypic and the phenotypic association is very important with respect to the timing of the prophylactic surgery, right? So let's look at another table, right, where we have risk of medullary thyroid carcinoma and genetic mutations in multiple endocrine neoplasia syndrome. So if you look at over here, there are various risk levels which have been classified. Now at the level of risk level D, the gene red testing should be done as soon as possible within the first years of life, and the age of action required for the first calcitonin should be 6 months if not done already, and the prophylactic surgery should be done as soon as possible within first year of life. In cases of risk level C, where the codon involved is 634, we have to do the red testing around 3 to 5 years, and if the not done, then the first calcitonin should be done at more 3 to 5 years, and the prophylactic surgery should be done before 5 years. Similarly, in the B, which have the codons affected 609, 611, 618, and 620, the red testing should be done at around 3 to 5 years of age, and the first calcitonin should be done at more than 3 to 5 years of age, and we need to consider surgery before 5 years, and we may delay in this. And in cases of group A, which is involving the codon 833, 819, 891, 912, then the age of prophylactic surgery should be between 10 to 15 years. I get it, this table might be very complicated for you all, but what I would want to remember for you is, in generally small, is that for men type 2A, the surgery should be done in less than 5 years. We can prophylactic surgery, and in cases of men type 2B, it should be less than 1 year, right? Because in general, men to be have rapid growth, right? Then they have a poor prognosis, right? They have a poor prognosis. At the same time, they have an early onset, and they tend to be aggressive compared to the counterparts, right? So even if you guys do not remember those table, I get it, it's very difficult to remember the codon. I would definitely ask you all to remember this particular part, where the prophylactic thyroidectomy in case of the men 2A is done in less than age of 5 years, and men 2B less than 1 year. A common funda to remember it would be, because when type 2B has rapid growth, poor prognosis, has an early onset, and it tends to be aggressive, right? So now we come down to the last part of this video, which is Men-4 syndrome, right? This is an extremely rare condition. So these are usually Men-1 associated tumor, which are parathyroid and pituitary, right? So in associated with tumors of kidney, adrenal and reproductive organs, also with pancreatic neuroendocrine tumor. So what is the most common mutation seen over here? It is the mutation in CDKN1B gene, right? So sorry for the wrong thing, it will not be CDKN1, it please let me write it down again. It is CDNK1B gene, right? So it is seen most commonly due to the mutation in CDNK1B gene, and the treatment would be same as Men-1 syndrome, right? So this is a very rare entity. Please remember the gene asked, as that may be asked to you, mutation in the CDK1B gene, and the treatment would be same as Men-1 syndrome. So this is all about your Men syndrome. Please remember the 3 P's of Men-1: pancreas, pituitary and parathyroid. In case of Men-2 syndrome, type 2A, type 2B, oral mucosal features are associated with type 2B. Men-1 gene involved is Men-1 gene. It is a tumor suppressor gene. In Men-2, it is a red gene, which is a proto-oncogene situated in chromosome number 10. In Men-1, it is situated in chromosome number 11. Then we have a prophylactic surgery. In case of Men-2A, it may be done up till 5 years of age. In Men-2B, we do it at less than 1 year of age. Why? Because of the common funda that it has an early onset, it is much more aggressive, and it has a poorer prognosis. And Men-4 syndrome, which is a Men-1 associated tumor with parathyroid and pituitary, along with kidney, adrenal and endocrine tumors of the pancreas and reproductive organ tumor, and the mutation involved is CDNK1B gene, right? I hope this video was very helpful for you all, and we might be getting around 1 to 2 questions from this in your FMG or NEET PG exam, which I think I have covered all in this videos. So stay tuned to your Global Academia Medical Education YouTube channel for more such videos. Thank you.